Wow, that was a lot of information. That was really packed with some really useful stuff. Okay, our next speaker is Dr. Troy Gatcliffe, who is a gynecologic oncologist and robotic surgeon with the Miami Cancer Institute at Baptist Health, South Florida. He earned his medical degree from the Royal College of Surgeons in Dublin, Ireland, and completed an internship and residency in obstetrics and gynecology at Boston University Medical Center in Boston, Massachusetts. Dr. Gatcliffe then joined the faculty at the University of Texas Southwestern Medical School and Parkland Hospital in Dallas as an assistant professor, teaching in the largest obstetrics gynecology training program in the country and earning a National Faculty Teaching Award. He completed a fellowship in gynecologic oncology at the University of California, Irvine Medical Center in Orange County, California, where his research interests included molecular signaling pathways in ovarian cancer and chemotherapy of cervical cancer. Board certified in obstetrics and gynecology, Dr. Gatcliffe is a fellow of the American College of Obstetricians and Gynecologists and the American College of Surgeons. He offers minimally invasive surgical techniques, including robotic surgery for all complex gynecologic and women's reproductive cancer diagnoses. He has a strong personal and professional interest in caring for patients from the Caribbean and Latin America, has lectured throughout the West Indies, and has worked with public and private sector physicians in several countries to raise the standard of healthcare for women with gynecologic cancers. Today, Dr. Gatcliffe is going to talk to us about the big C, the link between diet, obesity, and cancer. Please welcome Dr. Troy Gatcliffe.
Good morning. There's lots of seats, quite a few up front, so I don't want anybody having to stand on 9-inch heels. And if any of Dr. Yin's patients are here, you can have a private consultation with her. She's in the front row. So let's get everybody to come on up and find a seat. Don't be shy. I think we have ushers who can bring you up. I'd like to say thank you to the Ministry of Health and to all of you for inviting me again. It's a great pleasure and an honor for me to be here. Thank you so much for having me back. To advance, I just go one forward. There we go. Just one little brief slide about myself. I am a gynecologic oncologist. I am a surgeon, and I also give chemotherapy for women's cancer diagnoses. After finishing fellowship in 2010, I moved to Miami, and I was in private practice there for many years. And I've had the great pleasure of coming to Cayman and meeting all of you and having many of you as my patients since 2010. My kids now joke that when we come, they start to take bets on how quickly I'll run into somebody. And the other day we were Irma refugees, running from the hurricane, and we came to Cayman during the hurricane, went into Foster's, and right as we walked into Foster's, somebody went, "Dr. Gatcliffe!" So they were taking bets, so it's great to be here again. In terms of what we're going to try to get through, I'm not going to talk for a whole hour because I can tell you that my own personal attention span is right around 35 to 40 minutes, then I glaze over and the lecturer starts. So I'm going to try to keep everybody's attention and have everybody stay focused. Come on in, guys, and grab seats. There's some seats up here. It's like church. Nobody ever wants to come into the front row. We have some seats here. Come on in. So we're going to review obesity statistics in general. We're going to talk about the mechanisms of obesity and cancer. A lot of the things that I have said, Dr. Barsoon said, and that was a tough act to follow. A great lecture. I really, really enjoyed it. And some of the very same things that he spoke about in terms of biochemical mechanisms, I'm going to really hammer home in this talk as they relate to cancer. So hopefully all of you will really have a clear understanding of how mechanistically in your bodies obesity actually affects cancer. And we're going to discuss some of the health outcomes. I want to take a quick poll just of the audience. How many of you are not healthcare professionals in some way, just members of the public, just regular, normal, non-healthcare trained people? Let me see the hands, up, high. All right, so most people in here have some kind of healthcare background. but maybe about 10, 15, 20% are members of the public. So I've tried to pitch this talk to be able to speak to both people who have some healthcare background or understanding of physiology, and also to try to keep it interesting enough so that those of you who are not physicians and are just here to learn more about this topic can also follow along with us. I want to make a shameless plug for the Cayman Islands Cancer Registry. I've been encountering this issue with all of you guys who live here since 2010 when I got here. And I think that there's a real taboo, there's an issue in Grand Cayman about allowing your depersonalized, de-identified data to be used in the Cayman Islands Cancer Registry. And I can tell you that I can't find any good data on cancer statistics for Cayman. There just isn't any. And you want to know why? Because we have a taboo about letting that data be registered. And the only way forward to really understand what's going on from a cancer standpoint in Grand Cayman is to allow your de-identified, okay, anonymous data to be registered. And so I called the Cayman Islands Cancer Society, the Cayman Islands Cancer Registry yesterday. Spoke with Amanda. And so far, there are only 351 cases that are registered. That's it. And this is not a pie chart. Make sure what you're looking at is not a pie chart of incidence or prevalence of cancer. This is just what's been reported. So the most commonly reported cancer is breast cancer. The next most commonly reported cancer is colon cancer. So this is as much data as I can get on this country from the actual Cayman Islands Cancer Registry. And this is something that we all really need to take home and understand and improve, because in order to really understand what's going on the island and what's happening is to allow folks to register their data. And there's no need to be afraid about allowing your data to be registered. So one thing for sure, we have the Breast Cancer Gala, we have Breast Cancer Month. Breast cancer is very, very well understood in the public psyche, and therefore it's really highly reported. But breast cancer is certainly not the most common cancer overall, necessarily. It's certainly not in men, and it's something that we really need to improve. So I just wanted to make that plea as an oncologist to all of you, so that maybe 10, 15 years from now, we'd have better data, and when we come back and we look at these talks, we'd have a better idea of what's going on in these islands. So just as a kind of a background, just to set the stage for some of the stuff that we're talking about and to remind everybody in the crowd, what is cancer? Well, cancer is a term used to describe diseases in which abnormal cells divide without control. And about only 10% of cancers are actually attributable to a genetic defect. Most cancers have their roots or have their causes in lifestyle or environment. So there is this common notion that cancer comes from genes and gene problems that are passed down through your family. And that is not so. Only about 10% of cancers actually have a hereditary or a genetic or a familial link. Most cancers are caused by something that your body experienced throughout the course of your life or are in some way related to the lifestyle that you lead. And then the other thing that I struggle all the time with my patients is the notion that cancer is cancer. It's one big diagnosis, it's one big disease, and it happens in exactly the same way, whether it happens in your prostate, or it happens in your lung, or it happens in your breast, or it happens in your colon, and that is absolutely not true. Cancer is really just a term that describes over 100 different kinds of diseases, and the mechanisms for different cancers are so vastly different that they might as well have separate names. And unfortunately, they're all called something cancer, right? And that cancer word gets wrapped up in there, but they're very different. For example, as a gynecologic oncologist, and I've worked with Dr. Yin for years here to promote awareness of the HPV vaccine and cervical cancer screening, but cervical cancer is an infectious disease. It's really an infectious disease because most of you in the audience will know that cervical cancer is caused by a virus. If you never come into contact with that virus, you can never really get cervical cancer. So the HPV virus is the causative agent for cervical cancer. There's very few other cancers in which a viral agent is the causative agent. So cancers are very, very different. And most importantly, the bottom sentence of this slide, while many diseases such as heart failure and so on may have a much worse prognosis than cancer, there's this big, big taboo, about cancer, Oh my God, my mom has cancer, and people don't really want to say it, In Miami, where I work and where I live, and we have a huge Latino populations, Cubans don't like to talk about cancer. They talk about it in code. Latin people don't like to actually say the word cancer, because it's almost like if you say it, if you speak it, it becomes real and it's frightening. So cancer is surrounded with a lot of taboo, and there are lots of other healthcare things that happen in our lives and lots of other diseases that are far worse in terms of prognosis than cancer, but yet cancer really strikes fear into people. Causes of cancer, this is an important take-home slide for you guys to really look at. People know really well that things like tobacco and alcohol cause cancer, but look at the combination of physical activity, overweightness or obesity, and diet. Those three, from the green down to the teal blue there, account for over 25% of the causes of cancer. So linked together, your diet, what you eat, being overweight, if you are, and how much you exercise account for approximately 25% of the causes of cancer. And I think that this is something that the public on the whole and most healthcare professionals don't really appreciate. So the effect of diet, exercise, and being overweight as a cause of cancer is huge, up to a quarter or 25%. Basic concepts of cancer. What happens with cancer cells? Well, cancer cells are able to evade growth signals. They are able to replicate in an unlimited way. The bottom of the slide there, cancer cells have sustained angiogenesis. And that word is going to come up a couple times, and I want you to know what it means. Cancer cells and tumors have the ability to create and pull blood vessels into themselves to feed themselves. Angiogenesis is a huge target for the way we treat cancers today. And this is unique to cancer cells and unique to tumors, the ability of tumors to pull and create new blood vessels. No other place in our body, no other types of cells in our bodies have quite that mechanism the way cancer cells do. And of course, one of the most important hallmarks of cancer is its ability to invade into other organs and to metastasize, to go to distant sites. Let's talk a little bit about how food, nutrition, obesity, and physical activity affect things in your body. Okay? So things like DNA repair, the repair of your DNA, the ability to repair broken cells and make them whole again are affected by food and nutrition. The effects on your immune system, and Dr. Barsoon spoke about this in really elegant ways and in very elegant slides. Inflammation and its effect on things like heart disease. Inflammation and its effect on various cancers, and certainly carcinogen metabolism and how we metabolize carcinogens like smoking is affected by the things that we eat. So back when cancer treatment began in the late 30s and 40s and 50s, we were really focused on the treatment of cancer. How are we going to kill? How are we going to cure cancer? How are we going to get rid of it? We came up with radiation. We've had a whole era of chemotherapy. We had surgery. We have all these tools still. But I would suggest to you that really and truly we are now in the age of where we should really be focusing on cancer prevention in 2017. And diet, weight, and physical exercise play a huge role in how we can prevent cancers. So why is it important to actually prevent cancer? And this slide may be obvious to most of you in the room, but I think it bears saying out again. A lot of cancers we don't have great treatment options for. One of the most deadly cancers that I see and I treat every day in my office is ovarian cancer. We don't have a great screening tool for ovarian cancer. Over 80% of women with ovarian cancer will be diagnosed when it's already widely metastasized throughout their abdomen and will be diagnosed at stage 3. And so far, we are making some good strides in the last 10 years with the treatment of ovarian cancer. But the truth is that still in 2017, 80% of women with ovarian cancer, when diagnosed, will recur and they will die of their disease. We are not good at curing ovarian cancer yet. It's not a super common cancer, but it's a big killer of women in terms of gynecologic cancer. So for many cancers, we don't have great cures. Existing cancer therapies do not target specific cancers, and a lot of the treatments that we have really undesirable side effects. And one of the main causes of failure in the current system with chemotherapy that we have is the ability of cancer cells to evade the mechanisms by which drugs and chemotherapies work and to become drug resistant. They're almost like smart cells, just like viruses and bacteria. We have superbugs now. We have bacteria that can evade some of the commonest antibiotics that we have, and cancer cells have that hallmark as well. So I treat many patients in Cayman for cancer, and one of my own patients from Cayman came to see me in the office last week. She's been on 2 separate lines of chemotherapy, and she's become resistant to both lines of chemotherapy, and now we're going on to a 3rd line, hoping that that might be the thing that might control her disease. Let's switch now and kind of talk about obesity. And this is where, I was really, Dr. Barsoon, if he's somewhere in the room, I was really proud to listen to him speak so frankly and so openly about his own personal experience as a physician. You guys might look at me, saw me up there eating my little fruit cup this morning and think, oh, he's super healthy and he probably exercises and he's in good shape and blah, blah, blah. But this is a daily struggle for me, just like it is for almost all of us, So it's all about lifestyle. It's all about the choices that we make. And I want to tell you that I struggle as well. And when I show you some of the parameters by which we measure obesity, technically, if you really want to know, my BMI right now is 28. 28 is technically overweight. And what I proffer to you is, as a society, as a race, as a culture, especially in the Western world, our understanding of what it actually is to be a normal weight has become so warped that someone like myself that looks relatively healthy and looks relatively slim may actually really be technically, physiologically overweight. And we're going to talk about some of that in a moment. About 25% of Americans are currently either obese, are in fact obese as defined by a BMI of over 30 kilograms per meter squared. There are over 300 million people worldwide, and there are significant health risks, not just cancer, related to being obese. And of course, I think that this is something that we all agree on, and Dr. Barsoon spoke about it at length. There's a huge effect of American culture throughout the world. It's a very, very dominant culture. And one of the things that the US exports so well is fast food. And just think about that for a second. Think about how American culture and the way Americans eat pervades societies across the world. And this is now no longer just limited to the US. If you go into cultures in the Far East, and cultures that typically had very, very low BMIs, the effect of American culture and the effect of the processed foods that we eat are now reaching throughout the world. Even in the UK, 25% of people are now considered overweight or obese, and Asian countries where this was not really a problem, say 50 years ago, are seeing huge upticks in obesity. And you have to remember that with poor nutrition, you can actually be obese and malnourished, because you're not really eating the proper foods. This is an article that I pulled this data from, and it shows you the sharp rise in obesity and extreme obesity over the last few decades. So you can see that this is really a problem that's ongoing. If you look at the map now for the US on the right-hand side of your screen, there was no data or very, very low rates of obesity or overweightness in the United States. And here, as I click through, you're going to see what happens to the US over the decades to come. So what happens as time moves on is that in 2010, in many states in the United States, greater than 30% of the people in those states, especially in the southeast and the southern United States, where we like to eat grits, and we like to eat chitlins, and we like to eat pork, that's where the stuff is, right around the middle of the country. Throw a dart into the middle of the United States, and where do you hit? Kansas, all right? You know what's going on in Kansas? About 50% of the people who live in Kansas are overweight, because that's where we eat all of our good steak, right? So That's what's happening in the States, and often so goes the States, so go the countries that exist around the United States. So how do we actually assess obesity? What's the medical assessment of obesity? Most of you in the room know that obesity is usually assessed in various ways, but the most common way, as I've been talking about in my own personal experience, is body mass index. And body mass index is a simple formula that takes into account your height, your weight, and your gender. One of the most important things that happened to me in my own personal life, I'll share a story, is that when I finished residency in 1999 and moved to Dallas, of course, to like a big steak-eating state, Texans know their steak. I was terribly unfit. I wasn't terribly overweight, but I was easily about 20 pounds over where I should have been. And I was about to turn 30, and my wife said to me, you should really just go for a doctor's visit. And I hate doctors. They're a sordid bunch. I stay away from them as much as I possibly can. I really, really try to avoid doctors at all costs. So my wife said, you're turning 30. You have no idea about anything that's going on inside your body. And I said, I'm fit as a fiddle. What's the big deal? She said, you're turning 30. Go see a doctor. So I said, okay, fine. So just like Dr. Barsoon, it was the conversation of my wife that said, go see a doctor. So I went to see this doctor. I picked like the oldest, gray-haired, the guy that I thought would, do this. Right, okay, all right, you're fine. See you in 5 years. And I said to him, so, doc, what do you think? He says, well, you're all right. You're in pretty decent shape. He says, but here's what I want to tell you. Your cholesterol's okay. You seem to know that you should be doing some exercise and so on. For a man, so I'm speaking to the men in the audience now because that's what I am, even though all of my patients are women, right? He said, for a man, the one thing that you could always use as a little indicator of where you're going in life with your weight and your health is your waist circumference, your waist size. So he said to me, when you were in college, 19 years old, what was your waist size? I said, 34. He said, do you have any of those clothes around still? And I actually had a pair of jeans from when I was in college that I still had in a trunk, far packed away in a closet. And he said, what's your waist size now? 37. I was 30 years old. It was about 10 years after I'd left college, and my waist was 3 inches larger. 37 is not like the most terrible waist size for a man, but he said, what you want to do for the rest of your life is fit into the same pair of pants that you wore when you were 19. So I went home, right? I mean, that's what the guy said to me, and I thought he was going to be, out the door. And I said, holy moly, really? I mean, come on, doc. Cut a guy some slack. So I went home, I dug up the pair of jeans, and I went, holy moly. So I kept these jeans, I cut them into shorts, and I keep them in the bottom of my closet. And every time I feel I'm getting off track, I go and I try to get the jeans on. And so far, I've been able to bring myself back down to a size 34 waist. And so the issue is that we all make these choices. These are things that all of us struggle with. And so for men in the audience, if you think about your waist size when you were at your fittest and your youngest, that's what we should be trying to strive for. So if you look at, oops, where'd I go? There we go. So how much is actually excess weight? And if you look at this, this is where I really want you guys to think about how warped our own sense of what weight and being overweight is. So a normal BMI, not overweight, a normal BMI is anywhere between 18 and 25. 18 and 25. My BMI right now is 28. I am technically overweight. In order for me to bring my BMI into a normal range right now, I need to lose about 8 pounds. Now, my mother tells me and my wife tells you look really good right now. Just stay just like that. But the truth is that physiologically, I am technically really and truly overweight. And these are the breakdowns. So if any of you want to calculate your own BMI, you can pull up these things on your smartphone. If you pull up your gender, you pull up your weight, which you know, and you put in your height, how many of us really are actually a normal weight? So these are ranges for a typical 5'4" woman, okay? So in order to be a normal weight for a 5'4" woman, you're supposed to be somewhere between 122 and 144 pounds. If you're not, you're actually technically overweight. And a lot of us in the room are going, oh no. Oh no, 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 no. It's hard to look at. It's hard to think about. It causes a stir. It gives you like a little flutter, right? You know, because you really don't want to be called obese, because that sounds, yeah, right? But the truth is that many of us are actually in the overweight range. So data has been around for a very, very long time that suggests that if you're overweight, you have decreased survival, not just from cancer, but obesity affects many, many aspects of our health. And in fact, this is a slide that really, really caught my attention. In the next 3 years, by the year of 2020, 75% of the United States will be technically overweight. Not obese, but just overweight. And that has pervaded into our allowance of what we see as normal. We have changed. When we see someone that's actually now a normal weight, we think, oh my God, is she so scrawny? She needs to go and eat a good callaloo, yeah. Back at home in Trinidad, my mother would say, we'd bring her home and give her a good pilau and some breadfruit, and she'd be just fine. Because we think of people now that are actually within the normal weight range as being really skinny. And Dr. Barsoon spoke about the evolution of where we have come from and now what we have morphed into. And the truth is that this is a staggering number for all of us. So what is the awareness? Let's talk about a little bit about the awareness of what we think about obesity and cancer. So this is a slide, I hope it projects well, but everybody knows that tobacco is a problem. People know that genes are a problem. People know that sun exposure is a problem. Only about half of the population actually understands that obesity has something to do with cancer. So this talk is meant to convert all of you into disciples of the truth, right? Disciples of the truth that obesity actually has a major impact on cancer. And we want to change this perception so that everybody walking out of this room today understands that being overweight has a link to obesity, and hopefully in the next few slides I'll show you why. Perception has changed very little over the last 10 years. The public's perception of obesity being linked to cancer is not really improving. It's not going up. It's not really coming into our minds that obesity and cancer are actually linked. And in fact, here's the percentage of Americans who rate as their number one health concern. Look again at the taboo. Look again at the taboo. Cancer, cancer, cancer. She has cancer. Did you hear Arlene has cancer? People don't even want to. Did you hear she has the big C? It's like cancer strikes this fear into people, but yet diabetes, yeah, heart attacks. People aren't thinking about that. But yet cancer has this place in our mind as being something really, really terrible. Now look at the things that people consider are preventable. People know that diabetes is preventable, but a lot of us are not really on track for that. They think that heart attacks are preventable. Look at how many people think cancer is preventable. Because they think it's kind of like, oh my God, you got cancer. It's terrible, terrible luck. It really did. Other than smoking, everybody knows if you smoke cigarettes, you're probably going to get lung cancer. But people don't realize that being overweight is linked to so many cancers. So what's the actual data? Here's a great study from the New England Journal of Medicine that shows that as you increase in BMI, your chance or your relative risk, what is relative risk? A relative risk, for those of you in the room that don't deal with statistics every day, because I'm going to use relative risk a number of times in the next few slides. A relative risk of 1 or 1.0 is like no risk at all. It's no difference up or down. So if you have a relative risk of a variable X on Y condition and the relative risk is 1, there's no up or down increase in you having a problem associated with variable X. If you're on the plus side of 1, you're 1.2. 1.2 is a 20% increase in your chance of having that problem. And a relative risk below 1 is protective. So if the relative risk is 0.8, there's a protective effect of that condition of that variable on the condition. So you can see here that the relative risk of 1 goes up, and you start getting into the 1.5s and up into the 2s. And notice the difference between, and this is all cancers. This is all cancers. This is not specific to one cancer or the other. But notice the difference in the impact of obesity on cancer relative risk between men and women. Women are more heavily impacted by being obese, all told, for cancers than men are. And this is important because this is who my patients are. So Dr. Barsoon did a great job, but I really want to get a little bit more into this, but he really said these actual words, and I thought it was fantastic. Adipose tissue is an endocrine organ. Adipose tissue, I tell my patients who have endometrial cancer, is like walking around with an extra ovary. So if you think about it, after menopause, your ovaries stop producing hormones, your hormones become less, your sex hormones become less. But if you're walking around with a lot of extra weight, you have a lot of extra estrogen being produced by that extra adipose tissue. And that's true for women, and that's why obesity affects women in certain cancers in certain ways, but it's true for men as well. So adipose tissue is an active endocrine organ. And there are multiple mechanisms by which having much, much more fat on your body influence effects on cancer-related functions, such as the production of sex steroid hormones like estrogen and androgen in men, the effect of insulin, and Dr. Barsoon spoke about this in many slides as well. It affects insulin sensitivity, insulin production, and most importantly, insulin resistance. It has many effects on other hormones. Fat produces leptin. Leptin is a natural appetite stimulant. So the more obese you are, the more leptin you have running around in your body, the more you're going to want to eat, the more hungry you are, and then when you eat, it takes more food to satisfy the leptin levels. So leptin is produced by fat. So it's, again, a vicious cycle. And then one of the most important things that he also stressed is the effect of adipose tissue on inflammation. So again, candidate mechanisms in adipose tissue include insulin, sex steroid hormones, obesity-induced hypoxia, and migrating adipose cells also move around the body and affect all of these cycles together. Let's talk about some of the regular biologic functions of adipose tissue. Adipose tissue, again, produces adiponectin and leptin, which stimulate appetite and appetite balance. They have a huge effect on inflammation, a huge effect on metabolism. What about the effect of being overweight on just your blood pressure? So adipose tissue is microvascularly vascularized. The blood vessels that go into fat tissue are really, really tiny. They're not big blood vessels. The more tiny, tiny blood vessels you have throughout your body, the harder it is for your heart to pump blood through those really tiny vessels. If you're very, very overweight, you have tons more of these really, really tiny blood vessels feeding the fat in that tissue, and therefore blood pressure goes up. So there are multiple ways in which fat or being overweight increases various problems in your body. So let's kind of drill down in just one way, and I want to kind of take you through this so that you kind of really understand, especially for the healthcare professionals in the room, how is it actually that things like hormones produced by adipose tissue actually lead to cancer. So here's what happens. In adipocytes increase insulin resistance. If you're more overweight and you have more adipocytes and you have more fat on your body, you have higher levels of insulin resistance and you have higher levels of insulin production. So you see there right below the liver, you have more and more and more insulin the more overweight you are. If you have more insulin running around in your body, it signals your liver to decrease the amount of sex hormone binding globulin, SHBG. So the synthesis and production of sex hormone binding globulin goes down. Sex hormone binding globulin is what binds up sex hormones and prevents them from having their effect. If you reduce the amount of circulating sex hormone binding globulin, you then increase the bioavailability of hormones. This is just one mechanism. This is not the only mechanism, but I wanted to kind of drill down and really show you how in one case, in one way, in one mechanism, being overweight, being obese, feeds through multiple cycles and multiple different mechanisms in your body. So what happens if you're walking around with an increase in sex steroid hormones? So let's look at the effect of what it would have on estrogen. Here's a very elegant table taken from a 2003 study just showing you the difference in circulating estrogen across various BMIs. How do I go back? You go back by going back, right? There we go. So again, remember, overweight, increase in insulin resistance, increase in insulin production, decrease in sex hormone binding globulin, increase in circulating estrogen. Now look what happens across BMIs. Normal, remember, is the 22 to 25 BMI category. So estradiol and estrone, and then at the bottom of the screen, free testosterone in men, those are like the normal levels. So the normal amount of circulating estradiol in picograms per milliliter is roughly 8 for someone who is a normal weight. By the time you get up to just overweight or into the low obesity range, the level of circulating estradiol has gone up to 10. Now, 8 to 10 may not seem to be a big increase to you. It's not like, oh my God, it went from 8 to 50. But the bioavailability and the effect of having increased estrogen just from 8 to 10 circulating in a woman's body is profound. And this, for example, is one of the most important mechanisms for its effect, the effect of circulating steroids on breast cancer. And this is why there is definitely an effect between being morbidly obese or being obese and breast cancer. Here's the link, here's the mechanism. So for proof of principle, just for understanding that, we know all these fancy things, we've studied these things, but what happens if you look at it in reverse? What happens when you take bariatric patients, morbidly obese patients, and you operate on them, and they lose a ton of weight? In Scandinavia, they do a lot of bariatric surgery, and they have very, very elegant studies that have followed their populations over long periods of time, because Scandinavians love to register for registries. They always let their data be mined, and we have amazing, important data from people in Scandinavia that have helped the whole human race, because it's a very, very static population, and they have always been happy to allow their data to be used, their data, not necessarily their bodies, but their data to be used for medical research. So what happens when you take morbidly obese people, you operate on them, you do stomach bypasses, you do all of the different bariatric options that we have now, and you have a patient that goes from 300 pounds down to 175 pounds. Well, they've followed those people. And look at the effect between pre-operative and post-operative, especially in the women. On the left side is the men. There's not a profound effect on the men, but look at the effect of having bariatric surgery on non-fatal cancer incidence in women. It significantly shifted the curve to the right. What is this? This is a Kaplan-Meier curve. For those of you that know these curves and see them and work with them and read about them all the time in medical journals will understand. But for the rest of us, when the curve shifts to the right, that's decreased mortality, that's decreased incidence, that's a decreased effect. So the women in blue, or the women to the left curve, are the women that did not have surgery, and the women to the right are the women that had surgery. There was a significant splitting of the curves showing that the non-fatal cancer incidence in women markedly decreased in the women who lost weight as a result of bariatric surgery. And now this is both men and women together, just looking at cumulative mortality, all-cause mortality, not related just to obesity, but all-cause mortality from the people that underwent bariatric surgery versus controls. So significant weight loss, just as proof of principle, significantly improves lifespan. So let's talk about a couple of the cancers that have true and known links to obesity. And so there is strong, convincing evidence that overweightness is related to esophageal cancer through a very different mechanism, which I'll explain in a second, pancreatic cancer, colon cancer, breast cancer, endometrial cancer, and kidney cancer. There is probable evidence to support, especially in men, most importantly in women, but possibly in men, that gallbladder cancer is also linked to being obese. And I'm going to go through some of these right now in this slide. So again, the big cancers related to obesity: colon cancer, female breast cancer, one of the cancers that I take care of day in and day out, which is endometrial cancer, and we're going to talk about that mechanism. We have already looked at it on the mechanistic slide, but it's related to having excess levels of circulating estrogen. Kidney cancer, esophageal cancer, pancreatic cancer, and liver. So these are the big ones that really have something to do with being overweight. Let's look at men. Men, to begin, esophageal cancer. What's the mechanism? It's not due to circulating high levels of steroids. It's not due to inflammation. It's due to the fact that if you're overweight, if you're morbidly obese or very, very overweight, you have a lot of reflux. Reflux into the esophagus of stomach acid is the main causative agent of esophageal cancer. So the risk, remember the relative risk? The risk of having esophageal cancer if you are obese or overweight is 1.52. It's at the top of the slide. You have a 50% increased risk of having esophageal cancer if you're overweight and you're a man. Thyroid cancer, we don't know why. That has not yet been fully elucidated, but there is a marked increase in thyroid cancer with men due to being overweight. Colon, due to insulin resistance, and we'll get into that in a second. Renal, liver are the top, round out the top 5. So for men, these are the ones that really, really make a difference. Down at the bottom of the screen, you'll see a question mark. There's a slightly increased risk, but I think the data is becoming more and more strong that there probably is a risk, a link between being overweight, something to do with insulin metabolism, and prostate cancer. So I think that as the data becomes more and more clear, and as we investigate this more and more, we're going to realize that there are mechanisms in which obesity is related to prostate cancer. So again, this is the same data, just looked at in a different way. For the scientists in the room, you'll know that if the confidence interval does not touch the line all the way on the left, if the confidence interval does not touch 1, that is a statistically significant scientific finding. And again, you'll see that for all cancers, an increased risk in men, but most importantly for colon and stomach, pancreas, and liver. Let's look at women. The number 1 cancer is one of the cancers that I take care of all the time because this is a cancer related to increased levels of circulating estrogen. It's like walking around with an extra ovary, but in the postmenopausal woman, you don't have the progesterone from the ovary to counteract the extra estrogen. So you have unopposed estrogen. You have unopposed excess estrogen. So endometrial cancer, and for those of you that may not know the terminology, cancer of the womb, cancer of the lining of the uterus is the number 1 most often found cancer related to obesity in women. Gallbladder cancer, esophageal adenocarcinoma, renal for some unknown mechanism in women, again, leukemia and thyroid cancer, and most importantly, for women, breast cancer in the postmenopausal woman, significantly associated. So you have a 12% increase in risk. There probably are not a lot of people in the room that knew for sure that being overweight or being obese or being morbidly obese was actually linked to breast cancer. There is a link between breast cancer and being overweight. Again, this is the same data, just in a different form. So what I want you to look at is, this is a busy slide, but the cancers that have a sharp line going upward with a very, very tight pink line around them, such as uterine cancer, those are the ones that are most strongly associated with obesity. And again, for men and women, colon, women breast, liver, renal, gallbladder in women, endometrial in women. Here is emerging data, very, very recent data suggesting that in men, increased serum insulin levels are in some way related to an increased incidence, an increased risk for prostate cancer. So this data is new, it's emerging. We're still investigating why sometimes insulin and insulin resistance and increased insulin production has something to do with prostate cancer, but the data is becoming more and more clear. And here's what happens to women who lose weight, who have a sustained weight loss over some part of their life and their risk for having breast cancer. The more weight you lose and the more weight you keep off, your risk of breast cancer goes down. Let's talk a little bit about some of the very strong data that suggests this huge link between breast and obesity. So not to forget, there are genes, there are hormonal effects, but just being overweight or being obese or being morbidly obese certainly has an impact on whether you will die of breast cancer or whether you will recur. So on the bottom there, well, the numbers didn't come out too well, but that's basically on the x-axis is increasing BMI, and on the y-axis is the relative risk of having breast cancer. And the more obese or the more overweight is your BMI, the higher the chance that you are going to have a problem with breast cancer and survive it in the early stages. Let's look at colon cancer that applies to both men and women. A great cohort study of over 3,000, almost 4,000 men and women looking at stage 2 and stage 3 colon cancer, published in 2003, looked at the differences, and again, the differences are bigger and more impressive for women who are overweight and their risk of breast cancer. So again, you'll see the relative risk, the reference range for being normal is the 21 to 25 group for BMI. Those are the quote-unquote normals. As you become more and more overweight, you have up to a 1.34% relative risk or increased chance of having colon cancer if you are a woman. And that's very significant for people to know. So let's talk a little bit, as we wrap up my talk, a little bit about the cancers that I take care of in gynecologic oncology. There is a really clear, strong indication and strong association between endometrial cancer and between endometrial cancer and obesity. There's no association with vaginal and cervical cancer, and there's a possible association between cervical and ovarian cancer. So endometrial cancer, or cancer of the lining of the womb, is the most common gynecologic cancer in the Western world. It is the most common gynecologic cancer in the Western world. It's the 4th most common cancer in women in the United States, the 5th most common cancer in women worldwide. And it is caused by an increase in circulating estrogen. And where does that estrogen come from? It comes from excess adipose tissue. To give you a kind of an update on where we are in the last 20 to 30 years, there's a slight uptick in the number of cases, but there's a dramatic increase in the number of deaths. So endometrial cancer, as related to the increasing morbidity of the US population, is a real and true thing. So in 1987, when I was leaving high school and going to college, the deaths from endometrial cancer in the US were about 3,000. Now, about 3 decades later, we have almost a tripling or a doubling of that risk, of the number of deaths. So this is significant. What are the links and what are the mechanisms? It has to do with elevated endogenous circulating estrogen. So being in that hyperestrogenic state and having extra estrogen is the main mechanism. And there is a clear progression. We have mapped out how the endometrium, or the lining of the uterus, changes with excess estrogen. And what happens is there's a progression from normal endometrium to what we call complex atypical endometrial hyperplasia into the low-grade or low estrogenic cancers, such as grade 1 endometrial cancers. So there is a true causative agent, and we know what it is. It's being overweight or being morbidly obese. So again, this basically just repeated what I just said, but again, having excess estrogen from adipose tissue markedly increases the risk of the progression of complex endometrial hyperplasia over to endometrial adenocarcinoma. So what are the prevention mechanisms, for example, for endometrial cancer? Well, one of them is to put people on oral contraceptive pills to regulate their cycles, give them back the progesterone that they lack because of all of the excess estrogen that they're carrying around. But probably one of the most easy and benign things to do is for a woman to lose weight. And that's why we know that women who lose weight reduce their risk of breast cancer and reduce their risk of endometrial cancer. The data to support this has been there for a while now and is profound and is really, really well known and understood. So to wrap up, the cancer diagnosis is really an opportunity for behavior change. There are systems in place to support people that want to make lifestyle choices, that want to make changes in their lives to combat being overweight, to combat eating poorly, to combat all of the things that we all struggle with every day. Small changes, little tiny changes. You know, taking your waist size if you're a man from a 34 down to a 33, if that's where you were when you were 20 years old. Little changes make a difference. So in summary, there is no question that for many of the cancers that are the most common cancers that we deal with every day, an increase in BMI, an increase in body mass index is associated with multiple cancers. Obesity is a complex system. It has multiple mechanisms, sometimes through hormones, sometimes through insulin, sometimes just through physical effect. If you're obese and you have a lot of circumference in your abdomen and a lot of excess body weight, you have a lot of excess reflux. And that's the mechanism, for example, for esophageal cancer. So it's not just through some of these biochemical causes, but also just through real, true physical causes. And prevention is basically summed up by exercise, most importantly, weight loss and diet control. This is my email. You guys are welcome to email me if there was anything in the talk that was not clear. I give my email out freely to everyone. Our local rep is Rebecca Brooks. I think most of you know her. The best way to contact me is through my email. Thank you so much for having me back to Grand Cayman, and it's been my honor to be here.
Don't run away, Dr. Gatcliffe. Can I get another round of applause for Dr. Gatcliffe?